Well, hello, everybody. This is State Representative Joe Sosnowski. Represent the 69th District in the state of Illinois, which includes Winnebago County and Boone County. And we have a special guest from Swedish American Hospital here, Dr. Cole, joining us for this dialogue in which we're going to talk about just what's happening in the local area here from his perspective as a physician, working with Swedish American Hospital, and hopefully cover some topics. But Dr. Cole, can I turn it over to you if you'd like to do a little bit of an introduction?
Absolutely. Thank you for this invitation to participate. So James Cole is my name, and I am a trauma and general surgeon at Swedish American Hospital. I actually work for the University of Wisconsin, but this is where I do all my work. And I've been here for a little over 4 years. And this is sort of an unprecedented situation for us here. It's probably an unprecedented situation for everybody around the country. Interestingly, it reminds me a little bit of my last combat deployment in Afghanistan, sort of charged with strange and new problems and an unusual set of circumstances, and just working through the logistics and operations of all of it. So I'm setting up an incident command center most of my time as the medical advisor to the incident commander, trying to essentially create optimal workflows and in a safe and healthy manner, considering all the risks of COVID.
Well, I appreciate that. And obviously, like you mentioned, these are very unique times. Many people have not lived through anything like this, and this type of response that we've seen, not just nationwide but worldwide. Here in our community, I just wanted to drill down with you a little bit. Could you share a little bit about Swedish American, what you're experiencing locally, with hospital occupancy and those types of factors as you treat patients?
Sure. So if you want to just start with some numbers, we've had a lot of COVID patients roll through here, and I'm fortunate. I'm hopeful that this is the peak, but honestly, all I can say is I'm cautiously optimistic. We saw a max of about 49 COVIDs in the hospital at one time, and then probably at least half of that as rule-outs. But presently, we're down to 37 COVID positives, 10 rule-outs, meaning people with symptoms that we suspect likely have COVID, but the test results are pending. We had as many as 28 of those patients intubated, but now we're down to 14 at one time, which may not seem like a lot, but that's a tremendous amount of people to be on the ventilator. Oh, by the way, COVID patients who have COVID lung requiring intubation, they're not like your usual intubated patients. These are very sick, very difficult to manage patients that require sort of extreme critical care measures. It's very interesting. It's kind of like, it's unlike anything most of the intensivists have ever seen. Fortunately, only 24 of our ICU beds are occupied, but we had been up to 30. Now our ICU only holds 28. Okay, so we've had to open up an additional pod. And in addition, we opened up an additional wing, if you will, an area that at one time was an ICU, but had been offline for many years, but is now back online as an ICU to accommodate overflows. But as we've had decreasing COVID admissions, and as people have been getting better, and they are getting better, we've seen a slight decline, but we're still pretty full. I mean, we had not been admitting a lot of patients for a long time during this COVID epidemic, and our census was way down. But now our census is picking back up. We have 200 patients hospitalized right now, which we had been as low as about 125. We're slowly picking back up, and don't forget, although we've been doing necessary surgery, we have not been, urgent and emergent type stuff. We have not been doing any elective surgery. We're going to start doing that next week. So our inpatient census is most certainly going to go up. They'll continue to go up. So if you want to know, how we're handling it, how we're doing it, surprisingly, actually, everybody is doing very well. And I would say the morale is excellent for the most part. Despite, I would expect there to have been a lot more fear, trepidation to do their job and work. Interestingly, I've seen a lot of people act as if this is their opportunity to shine in a real crisis, to essentially, be the warriors, and fight this battle. I mean, it's pretty cool to see the morale, and people are supporting each other very well. We early on, we started this cohorting process where we screen people based on symptomatology in the ER, and we have a very complicated cohorting system where we put people with known COVID who are really sick, and some with COVID that are not that sick, and people COVID rule outs, and people that clearly don't have symptoms. And so we've segregated people into various populations from early on. And we have a dedicated COVID floor where only COVID positive patients go. We have dedicated COVID pods in the ICU and non-COVID pods in the ICU. I told you we had to expand our ICU to accommodate overflow patients. We've been augmenting our ICU staff with additional members to help provide all that additional layer of critical care. We continuously, we're talking real time, evaluate ICU bed occupancy, non-ICU bed occupancy, number of intubated patients, ventilators in use, amounts of PPE and general supplies. I've actually had to get additional ventilators on 3 separate occasions. We've never thought that we had not enough ventilators in the pre-COVID days, but as we saw more and more patients need to be intubated, and these patients stay intubated longer, we've had to request additional things from our other hospital in Belvedere, from the government. We got FEMA ventilators, plus we've got additional ventilators from the University of Wisconsin. So we're good to go in that respect, but it's involved sort of real and continuous monitoring and planning.
Can I ask you,
yes, sir,
just a quick question on that with supplies? Since you touched on ventilators, it sounds like, being able to work within your system. Other supplies, obviously, everybody would love to have a month's worth of supplies, PPE, et cetera. Have you experienced any drastic shortages, or are you fairly stocked up on needed supplies?
So thanks to John Cashmore, he's our logistics director. He has been on this, all over this. And we set up an incident command, and every day there's a report as to all of the critical supplies and PPE. When I say critical, I mean the things that we really want to know about. He tracks N95s, surgical masks, procedure masks, gowns, gloves, hand sanitizers, Sani-wipes, ventilator tubing, disposable stethoscopes, all of that, okay? And he reports us numbers of days, burn rate, what's ordered, reliability of various vendors. So he is really on top of this stuff. And so I'd say because, he's a pretty sharp guy, and he's able to anticipate, and we track the real-time data as far as how many patients we have and what kind of burn rate we have with various PPE. We're good to go.
Oh, that's good. Good to hear that perspective. I know, sometimes obviously you have to avoid the media and some of the discussions, because, we talk to folks like yourself in the field, and I think really that's what we found statewide here. I know certainly in maybe more hotspot areas, New York City, their burn rate was maybe a little higher, but even there, I think some of the discussion was still, they still had a week's worth of supplies, but they certainly didn't have as much as they wanted, but they still didn't get to the point where they ever ran out. So it's good to hear that with FEMA and with other parts of your organization that you're able to keep up without any concern. So it's good perspective to have.
But we are constantly gathering more in anticipation of the unknown, right? There could be another surge following Mother's Day. There could be additional surges throughout the summer. We really don't know. So So we, as a matter of fact, we have this conference room downstairs that normally houses, in non-COVID situations, like 150 people. That room, all it is right now is a storage room with extra stuff. You cannot even walk in that place because we have so many extra supplies that we're not used to having.
Sure. Good. You kind of touched on a couple of the questions I had as follow-up, but one that is, I think, associated was you mentioned a little bit about capacity and how, usually you have maybe 125 beds filled. So when we talk about elective surgeries, those, non-critical, and the prospect of those beginning again, especially for those patients who, I'm sure you're in the process of identifying with your different medical personnel as far as ranking and which ones, are maybe more critical or important than others. How does that get handled? How do you mix that in with, your capacity of the system? Is that doable? Do you foresee
Yes.
any problems?
Again, it's one of those things you have to continuously evaluate, right? But we've been planning for this for a long time. And whereas, when I said 125, I meant that was 125 was a low number weeks ago when nobody was coming to the hospital. But normally we're in the 200s, sure. Right? So we're back up to about 200. But so we've been anticipating this. We've had about 600 plus patients have had their elective surgeries canceled because of COVID. Well, we've been gathering every single patient who's had their surgery canceled. We've been tiering them by levels of urgency. And of course, now that we're going to be allowed to start doing elective surgery, we haven't had to craft this process as to how we procedurally or pre-surgically COVID test them. And of course, there's just a number of people we've had to work through. We had to work with our ambulatory surgical side, our testing center, the laboratories, the various laboratories, other personnel, just to contact them, how to contact the surgeons as to what patients can be released, to have surgery, and all at the same time not overwhelm the system. So we do it in a slow, we do it slow initially, and we're going to ramp up as we realize that our system can tolerate it based on PPE, bed availability, and so forth. And honestly, if we fall to less than 20% of certain things like certain beds, ventilators and stuff, certain levels of PPE, we're going to have to scale back down. And so this is a constant moving target that we evaluate every day. But right now, we're good to go. And obviously, there are little problems that we recognize that come up on a day-to-day basis, but we have crisis intervention teams and working groups that just solve these problems.
Great. Appreciate that. And we don't need to get into a lot of detail. I wanted to mention a couple stats. You're probably familiar with it, but the county health department reports daily. And I wanted to ask you just, I think it's important to give some perspective to folks who may be listening to this, because, obviously you could imagine people that call my office, probably people that you interact with. There's a varying degree maybe of fear or concern. And according to a recent report, I think just yesterday, there was approximately 780 some documented COVID cases in the community. And out of the ones that we've seen, I think they're recording 26 deaths. Now, those numbers may change a little bit with the State Department of Health. But then if you talk to the coroner's office, and you probably know this, but there's somewhere in the area of about 1,100 deaths that have happened in Winnebago County this year. And of course, those cover natural causes, cancer, a variety of chronic issues. And so the reason I kind of mentioned some of it, not to get into too many statistics, is, I have people reach out to us and say, oh my gosh, what's happening? It's widespread everywhere. But and again, nobody wants to talk about death and those negative things, but, I try to mention in context, unfortunately there are people that pass, every day, every week. And I guess I want it, without getting into numbers necessarily, yeah. But, in any hospital system, obviously you're dealing with people in critical conditions many times. Do those numbers kind of correspond with, what you're seeing? How worried should the general public be about the number of deaths that have happened in Winnebago County versus the number of cases, just from your perspective?
So here's what I can say. I think that if we tested everybody, which of course nobody has that ability to do that, I think that there'd be a lot more COVID out there that would sort of lower the mortality, right? So if you have X number of deaths over a particular population, but you expand that population, but the same number of deaths, it's going to be lower. So not only do I track Winnebago County, I track Boone and Ogle counties, because obviously it's sort of our network where people come from. And based on the number of COVID diagnoses and the deaths directly attributable to COVID, the mortality is about 3.5%. 3.5%. But I mean, I would imagine that there's at least twice that many people that have COVID that don't know about it. So, that would lower that mortality. The thing about COVID is you just don't know, honestly, who's going to get sick. We thought we knew, but we don't, right? Because we've seen young people, we've seen old people, we've seen people with certain comorbidities. Fortunately, most of those people are not even sick enough to go to the hospital, like 90%, or at least 89%. And then, of course, those that are hospitalized, maybe half of them have to be in the ICU. So the bottom line is there a reason to be concerned? Absolutely. Which therefore makes it incumbent on everybody to be smart. Wear a face covering so that you don't spread it to somebody if you're asymptomatic. Wash your hands, safe, socially distant, but at the same time, since the mortality is, like I told you, single digits, if you get COVID, it doesn't mean the end of the world, but be smart about it.
Yeah, well, I appreciate that. And one note I didn't mention, I was going to follow up, again, according to what we're seeing from the Department of Health, and these numbers are a couple days old, but, out of those deaths, it does seem at a drastically higher percentage, and I think it's somewhere in the high 60% range. It seems, those deaths are recorded with people that had comorbidity. They had cancer, they had immune deficiency issues, a variety of other things. I know you can't get into details, but would that be accurate with what maybe you see as Swedish American with those cases too, or those who are most affected, I guess?
So the sickest patients seem to be those that have heart disease, kidney disease, lung disease, and morbid obesity. I mean, those are the four numbers. Okay. And as you know, young people can have that, older people can have that. And so it's really people that started out sick, but that's not exclusively the case. So we have had some younger people that didn't seem to have any comorbidities that have gotten pretty darn sick, but there may be some undiagnosed physical ailments, or who knows, maybe they smoked a lot or actually vaped. Probably that's what we're concerned about, vapors possibly being more at risk. But we don't know. At this point, we're going to learn a lot after this is drilled down upon, probably over the next year.
Speaking of the, and this is unknown also, and I don't know if you have any insight on this, but I figured I'd ask it since it pops up every now and then, but the antibody testing that we hear about in some states. I don't believe in Illinois we've started any, but New York, and I know from what I understand, it's inconclusive right now, but some of the initial testing, back to your point, there were maybe a lot of people that have it, but didn't even know it, didn't have many symptoms. Any comment that you can make on what do these antibody tests really mean in the long run?
So there's two types of antibodies. There's what we call IgG and IgM. IgM is the early phase antibody that shows up in your body within a couple of days of being infected, and then it goes down quickly. IgG develops later and stays longer, if not forever. Okay, often IgG is going to be in your body the rest of your life. Okay, and that confers immunity if we believe that it's the same exact virus from year to year to year. But as you know, for example, influenza, the virus mutates, right? So it changes. So we have to get a flu vaccine every year because the virus changes. We don't know what's going to happen with coronavirus. We already know that coronavirus has, in some way, shape, or form, at least mutated in parts several times. So that's what the virologists and the immunologists are going to have to figure out when they're developing this vaccine, because unless they pick the right protein or sets of proteins or core structure, whether or not we have antibodies may not matter at all. All it'll tell us is, yeah, it looks like you've been exposed in the past, and that's interesting, if nothing else.
Good perspective. One last question. Just in regards, you can comment as much or as little as you want on the debate. Obviously, we see states around us starting to open up a little bit more. Iowa and Indiana maybe are two closest. states, are allowing some form, reduced capacity of dining and more of those quote unquote non-essential businesses to reopen at again, reduced capacity. You can comment on that in general. Obviously, Illinois is following a different blueprint right now with what the governor has laid out, but how that affects the health system. You touched on this previously, so I probably know your answer in the sense that you have to evaluate it maybe day by day, but do you see negative effects as we reopen a little bit more, whether it's our surrounding states or Illinois in the future, and how do you handle that, going forward as a health system?
I mean, the first thing is, don't forget, I mean, you know this better than anybody, from an economic perspective, this is really hurting people, and people need to work. They need to earn a livelihood. They need to earn a living, feed their family, and this is really hurting. So I think unequivocally at some time, we have to get back to working so people can support themselves. And when we flatten this curve, when we work to flatten this curve, the goal was never to eliminate coronavirus. It was to decrease the rate of rise of coronavirus so that the hospitals had time to adjust to the capacity. Like if you have this huge number all at once, it overwhelms the system. But if you have a moderate number over a longer period of time, even though maybe the same number of cases may be seen through the systems, at least we can handle it over a long period better than if we had to handle it over a short period. So, I mean, we're prepared to handle this thing for a long time. I mean, I have a feeling from the hospital perspective, we're going to be dealing with coronavirus for the next year or two or more. So we're prepared to do that.
Yeah, and that was my a follow-up question I was going to ask. There's been some discussion about when it gets to a certain point, but like you just mentioned, flu hasn't gone away; it mutates. It's very difficult to eradicate anything 100%. So when you say we're probably dealing with it a couple years, I mean, realistically, even with a vaccine in the future, is there much hope of, well, I shouldn't say is there much hope, but you're confident that, as we progress and understand more about it, that our systems can adjust and compensate.
Yeah, I mean, we're going to change, everything's going to change, but necessity is the mother of invention, right? So we have to change, and we will change, and we are changing. And maybe if we're really lucky, kind of like SARS and MERS, they basically mutated themselves out of existence. So nobody needs a SARS or MERS vaccine. Maybe if we're really lucky, coronavirus will mutate itself out of existence. But if not, hopefully there will be some sort of vaccine available to mitigate that, down the line. But we have to adjust, and we will adjust.
Okay. Well, I appreciate it, Dr. Cole. We're kind of at our time limit here. I didn't want to take too much of your time, but I did want to leave it up to you if there's anything that we missed or anything additional that you wanted to comment on before we close out.
No, I mean, I think we covered everything, and I think the questions were great, and I appreciate the opportunity to share our side or my side, and hopefully this will get better before it gets worse, and I think it actually is getting better. So I'm going to remain, like I said, hopeful and cautiously optimistic.
Good. Well, cautiously optimistic, I think, are two key words. And from behalf of my staff and myself and my family, just thanks for what you do on the front line, and to all the staff at Swedish American. We're blessed with a wonderful health system here in Northern Illinois, and I know you serve more than just the Rockford area. But thanks for what you do, and thanks for your time with us today, and have a great weekend coming up.
My pleasure. Thank you for everything.
All right. Thanks so much. Have a great day.
Okay, too. Bye.